Good afternoon. A warm welcome to all the doctors present here. I am Dr. Vidya Shenoy from Bangalore. One of the most challenging aspects in endodontics is dealing with failed root canal treatment. So, today's topic is non-surgical endodontic retreatment, a conservative approach in treating cases with endodontic treatment failure. I will discuss the following aspects of endodontic treatment failure. That is, why did the RCT fail? Why to retreat the tooth with endodontic treatment failure? When and how to do the root canal retreatment. Endodontic treatment is one of the most technically demanding procedures in dentistry. The prognosis or outcome of endodontic treatment is dependent on variety of technical and biological factors. Few such factors include correct diagnosis, instrumentation, thorough disinfection of the root canal system, and finally how the obturation is done. So along with these things, respecting the root canal morphology and avoiding complications during treatment are very important factors which decide the prognosis of endodontic treatment. When a patient reports with failed root canal treatment, we often evaluate the ease or complexity of retreatment, the procedures that might be involved in the treatment, or the number of appointments that might be required for the retreatment. Of course, these things are important, but along with this, having knowledge regarding the causes of endodontic treatment failure will help us in treating the tooth better. So, we will see the causes of endodontic treatment failure in the following slides. Like I mentioned, there are biological causes and technical causes for endodontic treatment failure. I will first discuss the biological causes. Under this, there are microbial and non-microbial causes. Microbial causes include both intraradicular and extraradicular infection. The microorganisms that are predominantly present in a failed endodontically treated tooth include bacteria such as E. faecalis, Propionibacterium or Streptococcus, and fungi such as Candida albicans or Actinomyces. So these microorganisms, they might not have been eliminated completely from the root canal space, or they might have found a pathway to reinfect the root canal system. So here the non-microbial causes, as you can see, there are many non-microbial causes listed. The first one is cystic apical periodontitis. So in cases where periapical cyst was present, just the root canal treatment might not be enough to heal the tooth. So here it is important to differentiate between pocket cyst and a true cyst. The periapical pocket cyst, which is in continuation with the root canal system, might heal after the primary root canal treatment, but true cyst, which is independent from the tooth, will remain even after the root canal treatment is completed. So in this case, periapical surgery might be required to eliminate the cyst. Next one is the cholesterol crystals. These are formed by disintegrating RBCs or lymphocytes or macrophages that die in the periapical region. So they induce the formation of granulomatous lesion, which in turn induces inflammatory reaction. So this will hamper the healing of the tooth after root canal treatment. Foreign bodies such as Gutta-Percha, cotton pieces that we use to seal the tooth, or food particles that might have entered the canal during in between appointments, or any restorative material, sealers or calcium hydroxide, all these things can lead to inflammatory reaction in the periapical region and prevent healing. The last one is the scar tissue healing. So sometimes when a radiolucency is present in the periapical region of an endodontically treated tooth, we might mistake it to be a radiographic sign of failed endodontic treatment, whereas in reality it could be a healing lesion. This image shows the potential sites where microorganisms can accumulate in a root-filled tooth. As you can see, microorganisms can be present in voids in filling material, voids between root filling and canal wall. So to avoid this, it is necessary to create a very well compacted obturation which is free of voids. Compacted dentin chips will have infected microorganisms in them. This happens because during biomechanical preparation, the dentin debris which is present in the canal might get compacted in the apical region of the tooth. So to prevent this, it is important to recapitulate using smaller files during canal preparation. The microorganisms can also accumulate in the lateral canals, or they might get extruded into the extraradicular space during biomechanical preparation. E. faecalis is the most predominantly found bacteria in failed root canal treated tooth. There are many reasons for this. First is that it can survive prolonged duration of starvation. Second reason is that it has an efficient proton pump which helps to regulate the internal pH, and as a result of this it makes the bacteria resistant to most of the intracanal medicaments. E. faecalis can grow as monoinfection without any help from other bacteria. So eliminating E. faecalis from the root canal system is the most challenging as well as very important for the success of root canal treatment. These are the technical causes of failure of endodontic treatment. Poor aseptic technique due to improper or no isolation leads to further contamination of the root canal system. Use of incorrect irrigant might not lead to proper disinfection or proper removal of the infected pulpal tissue. Inability to prepare the canal to the working length leads to accumulation of infected debris at the root apex and also accumulation of infected pulp tissue at the root apex. Missed canal is another reason for failure of root canal treatment. Procedural errors during biomechanical preparation such as ledge, zipping, instrument separation, etc. causes improper cleaning and obturation of the root canal system. Poor obturation leads to void, which leads to microbial accumulation. Poor restoration of access cavity causes coronal microleakage, leading to contamination of the root canal system. So, identifying the technical cause for failure is important in decision-making process for retreatment. This was a study carried out at the University of Washington School of Dentistry to evaluate treated endodontic cases and ascertain the causes of failure. They have evaluated various technical causes and they found that among the teeth evaluated, incomplete obturation was the leading cause of failure of root canal treatment. Incomplete obturation can be caused due to improper cleaning and shaping, which is a result of loss of working length due to debris accumulation or other procedural errors such as ledge, zipping or instrument separation, which can occur during root canal preparation. So, having understood all the causes of failure of root canal treatment, sometimes we are left wondering that I have followed all the aspects of treatment protocol accurately with utmost care and precision, then why has the root canal treatment failed? Here, what we should also keep in mind is that even when the highest standards and the most careful clinical procedures are followed, failures can still occur because of the anatomic complexity of the root canal system. The root canal anatomy is so complex that it is impossible to achieve 100% cleaning of the system. Understanding this will make it easier for us to accept the failure of root canal treatment that we have performed. Of course, failure hurts, but facing failure makes us stronger and wiser to deal with it in a better way. We learn from it, we become logical thinkers, and then move on to find a solution and succeed. So now what is the criteria to determine whether a root canal treatment is successful or not? This is a criteria put forward by Stringberg. As you can see in this table, he has given various radiographic findings based on which we can determine whether a root canal treatment is successful or not. According to this author, The tooth has to be evaluated every year for radiographic signs, and at the end of 4 years, presence of periapical radiolucency is an indication of failure of root canal treatment. Again, this is a criteria put forward by European Society of Endodontics. As you can clearly see from this table, they have listed both clinical signs and radiographic features based on which we can determine whether a root canal treatment is successful or failed. So according to the European Society of Endodontics as well, the root-filled tooth has to be evaluated every year till up to 4 years, and then based on these clinical signs and symptoms and the radiographic features that have been listed by them, we can determine whether the treatment was successful or not. So based on these criteria, once we decide that the endodontic treatment of a particular tooth has failed, how do we proceed from there? Firstly, rule out any non-odontogenic etiology for failure. Then perform the clinical evaluation, such as periodontal evaluation to check for pocket mobility, to see if failure is due to any periodontal etiology. Check for tenderness of the tooth, swelling or sinus tract associated with the tooth. Evaluate the radiographic findings such as periapical radiolucency, quality of obturation, etc. And if there is any separated instrument or ledges or any other procedural errors can be evaluated from a radiograph. Then arrive at a definitive diagnosis and decide on the treatment options. Once we have arrived at a diagnosis, we have 5 possible treatment options. That is review or do nothing, non-surgical endodontic retreatment, root and surgery, extraction or referral. One of the most difficult decisions we have to make is whether to retreat a root-filled tooth that requires a crown when it shows no evidence of a defective core or periapical disease and is symptom-free but has a technically deficient root canal filling. So in such cases, what we should keep in mind is majority of the treated cases that develop apical periodontitis will do so within 1 year. So keep the tooth under observation for at least a year, and then if there is no signs of a failure, you can go ahead with the crown. So review may be considered when the tooth is symptom free, there is no systemic risk by no intervention, there are no signs of inflammation or infection, the tooth does not require a new restoration, or the root canal treatment has only been recently completed and the outcome is uncertain. Non-surgical endodontic retreatment is preferred especially when the failure is due to a technical deficiency. So I have discussed different technical causes for failure in the previous slides. So if there is any technical deficiency which is causing failure of the endodontic treatment, we can go ahead with non-surgical endodontic retreatment. Root end surgery is considered when it is impractical to carry out conventional root canal retreatment. For example, if there is a very large post which is well cemented in an already weakened root, the removal of the post might result in fracture of the tooth. So in such cases, we can perform root end surgery. Another indication for root end surgery is when the root canal treatment or non-surgical root canal retreatment has been unsuccessful. Or it can be done as an adjunct to root canal retreatment, as in cases of perforation, repair, or to remove extruded material. Or when root or tooth resection is required, or when biopsy is required, or for investigation and exploration, such as in case of root fracture. All these situations we can do root end surgery. Extraction is done if a tooth is unrestorable or the prognosis of root canal retreatment is poor. So in case where the tooth or the root is fractured or is not savable, if an alternative such as RPD or FPD or implant based solution would offer a better prognosis for that particular tooth, extraction is an option. Or when the patient elects to not have a retreatment when all options have been explained. So in these cases, extraction of the tooth can be is done. Referral is appropriate when the clinician is unable to make a diagnosis or access is limited and it requires a specialist for the treatment. Complexity of treatment is greater than the clinician's expertise, or there is a combined multidisciplinary problem, referral can be done. In this presentation, I will discuss non-surgical endodontic retreatment. So this is the overview of the treatment procedure. First is establishing a coronal axis. This includes removal of coronal restoration or removal of crown or creating access through crown if a crown is present. Next step is removal of post if it is present. After this, the obturating material is removed, followed by removal of separated instruments if present. Then comes the management of any canal impediment such as ledge if it is present, and finally chemomechanical preparation and obturation is done. I thank all the doctors who were part of this presentation, and I thank Coltene for giving me this wonderful opportunity to present my topic here. So for the coronal axis, like I said, if a restoration is present, it can be just removed and then we can carry on with the treatment. But if a crown is present, the decision is simpler if there is a defect associated with the crown, or if the treatment plan calls for a new crown, the old one is simply removed. But when the crown is considered to be satisfactory, then the decision becomes complex. In such cases, we need to consider the advantages and disadvantages of retaining the crown. Advantages of retaining the crown include cost for replacement can be avoided, isolation is easier, occlusion is preserved, aesthetics will be minimally changed. Disadvantages of retaining crown include retreatment may be more difficult, there is increased chance for iatrogenic mishap due to restricted visibility. There is chance of missing any hidden recurrent caries, or if there is fracture of the tooth below the crown, it can be missed, or if there is any additional canal below the crown, that can also get missed. But sometimes even if the crown requires replacement, the clinician may elect to retain it during retreatment for the sake of isolation. So once we have considered the advantages and disadvantages and we have made the decision whether to retain the crown or not, we can go ahead with the treatment. So if the decision is made to retain the crown, then an access is created through the crown. So for this we can use different burrs such as carbide fissure burrs, round diamond to access through its ceramic, and transmetal burr if a metal crown is present. If the decision is made to remove the crown, there are many clinical procedures that can be done. So there are many crown remover devices in the market currently. Few examples are HyFlex, automatic crown and bridge remover, Crownomatic, etc. Also ultrasonic tips such as simple scalar tips, for example biosonic piezo scalar tips from Coltene, or specialized tips are also available for removal of crown. Or what we can do is we can simply section the crown using a burr and elevate the separated pieces to remove the crown. Next step is removal of post if it is present. So basically there are three types of posts that are used, that is screw post, custom cast post and fiber post. We'll see how to remove all three types of posts individually. Firstly, to remove screw post, the simplest method is to use a wrench which is provided by the manufacturer for insertion of the post. So first step in removal is to uncover the head of the post using diamond burr. Then remove the cement around the post using ultrasonic tips. Then place the wrench over the head of the post and rotate it anti-clockwise to remove the post. For custom cast post removal, the easiest method is to cut a notch into the cast core using a burr. Then place an ultrasonic tip into the notch. This allows ultrasonic vibration to be applied along the long axis of the tooth, which will loosen the post and help in removal. Also, there are several post removal devices that are present, such as Egler post removal kit or Ruddle post removal kit, etc. Now, what to do if the post is fractured? In such cases, Maceran kit can be used for removal of the post. This kit consists of trifines, which is used to create space around the post by rotating it. Then an ultrasonic tip can be used to loosen the post and retrieve it, as you can see in the picture here. The most efficient method to remove the fiber post is to use the drills provided by the manufacturer for removal. Another method is to use ultrasonic tips to loosen the post in the root canal and retrieve it, as seen in this image. Even high-speed burrs have been used to channel down through the post, but in this technique there is high chance of root perforation. Erbium YAG lasers are also found to be highly effective in removal of fiber post, and it is used in the technique as you can see in this image here. This is a comparison of various post removal techniques. Manufactured removal kits causes less wear of root structure and was found to be faster than ultrasonics. Few authors have found it to be less effective than ultrasonics, whereas few authors have found it to be equally effective compared to ultrasonics. The ultrasonics removes post within 10 minutes according to a study, and the temperature increases from 30 to 38 degrees Celsius, and ultrasonics have been found to be more effective in combination with manufactured drills. Burrs cause greater loss of tooth structure, and with erbium YAG laser there was no visible damage to the root surface, and it removed post within 1 minute and 30 seconds, and the temperature rise was within 25 to 28 degrees Celsius. Now what do we do if we are unable to remove the post? In such a situation, if the removal of the post was for restorative purpose, then we should evaluate if the tooth can be adequately restored with the existing post or the post segment, and then if it is possible, we should go ahead with the restoration. If the tooth cannot be properly restored without removal of the post and placement of a new post, extraction and replacement with an implant or an FPD will be required. If the reason for post removal is the persistence of disease, then the tooth should be treated surgically and restored as well as possible. Next step in non-surgical endodontic retreatment is removal of the obturating material. Traditionally, silver points were used to obturate the canal, but its use is now discontinued since it does not produce three-dimensional seal of the root canal system. And silver points corrode when they come in contact with tissue fluids or irrigants, and the corrosion products are found to be cytotoxic. But still we might come across cases which have been obturated using silver points and require retreatment. So how do we remove these silver points? In most of the cases, the silver points can be easily removed since chronic leakage would have led to reduction in seal and retention. So for removal, initial access is done with high speed surgical length burr. Then use ultrasonic tips to remove the restorative material to expose the silver point. After this, there are different techniques which can be used for retrieval. So one of the technique is to use pliers such as Stieglitz plier. So while using this plier, the silver point is first grabbed using the Stieglitz plier. Then rather than pulling it straight out of the canal, try to rotate the plier by taking leverage against the restoration or tooth structure to enhance the removal efforts. Another technique is the use of indirect ultrasonic. So this technique is used when a segment of silver point is encountered below the orifice and the space is restricted. So in this technique, once the surrounding restorative material is removed, place the plier in contact with silver point and then ultrasonic energy is transmitted onto the plier to enhance the retrieval efforts. Another technique is braided file technique. So in this technique, headstrong files are used. Use small H files to gently screw in as far as possible. Then the files are twisted together and pulled out through the axis, as you can see in this image. Another technique is to use coffilled silver point retrievers. This is used when not much of the silver point is exposed in the chamber. As you can see in this picture, this instrument is a spoon-shaped instrument with a groove at the tip. So this can engage the exposed end of the silver point, and then it can be elevated from the canal, or it can be elevated to a point where it can be grasped using a forceps or a plier and removed from the canal. Different Gutta-Percha removal techniques include mechanical, chemical and physical techniques. Mechanical techniques include the use of GG drill, piezo reamers, K-files, H-files and microdebriders. But each of this technique has certain drawbacks. There is a risk of root perforation while using GG drill or piezo reamer. Use of hand files is very time consuming and it has to be used along with solvents. The chemical method involves the use of solvents to soften the Gutta-Percha to aid in its removal. But a major drawback is that all the solvents have some level of cytotoxicity and its use should be avoided if possible. Also, due to its cytotoxicity, if solvent is extruded into the periapical region, it causes severe pain in patients leading to mid-treatment flare-up. Physical techniques include the use of heat transfer devices, ultrasonic tips and laser. But the major concern while using these devices is the high heat generation which might damage the periodontium. Also, with ultrasonics there is a chance of possible root fracture. Nowadays, newer mechanical technique, that is the use of retreatment files, is done for Gutta-Percha removal and it is found to be highly efficient and time saving. One such example is HyFlex REMOVER from Coltene. I will discuss about this in the further slides. The use of retreatment files for Gutta-Percha removal has gained wide acceptance and popularity in Gutta-Percha removal. So how do these retreatment files remove Gutta-Percha from the root canal? So when these rotary retreatment files rotate, it produces heat. So this heat causes plasticization of Gutta-Percha, which results in softened Gutta-Percha that is less resistant and easy to penetrate and remove. So HyFlex REMOVER is an innovative retreatment file from Coltene. The speciality of this retreatment file is that it uses a single file to efficiently remove Gutta-Percha from the root canal without the use of solvent. This feature saves a lot of chairside time and makes Gutta-Percha removal, which is the most challenging step in retreatment, easier. This file is available in two lengths, that is 19 mm and 23 mm. The size of remover file corresponds to ISO size 30 with a 7% taper. It can be used at a torque of 2.5 Newton centimeter and speed of 400 to 800 rpm. The remover has a non-cutting tip which helps to prevent ledge formation. So these are the features of HyFlex REMOVER file. It has a non-cutting tip of 0.3 mm diameter which allows for safe use in curved canals. It has a variable triple helix cross section which is symmetrical in the first 3 mm, then asymmetrical towards the shaft. So this preserves the crucial periradicular dentin and enhances the fracture resistance of tooth. HyFlex REMOVER has a 7% taper which is limited to the first 10 mm and then it has a 0% taper towards the shaft. Again, this preserves the periradicular dentin and increases the fracture resistance of tooth. HyFlex REMOVER is manufactured using a C-wire heat treatment which increases flexibility and cyclic fatigue resistance of the file. So we'll see the technique to use HyFlex REMOVER file. Once the access is reopened, use the HyFlex EDM orifice opener file. Introduce it into the Gutta-Percha up to 2 to 3 mm at 400 to 800 rpm speed to create a pilot hole. Once the pilot hole is created in the Gutta-Percha, use the HyFlex REMOVER file at 400 to 800 rpm. Using a very light apical guidance till slight resistance to inward movement is felt. So once you feel the resistance, at that point pull out the file by leaning onto any selected canal wall to dislodge the Gutta-Percha. Then again reintroduce the file and continue it till all the Gutta-Percha is removed. So all the filling material can be removed in 3 to 4 in and out motion in apical direction. These are few cases which have been treated using HyFlex REMOVER file. You can see in this access cavity how cleanly it has removed the Gutta-Percha, and also in the radiographs as well you can see that the Gutta-Percha has been efficiently removed from the root canal and then the treatment has been done. How to do retreatment in cases obturated with bioceramic sealers? Various authors have evaluated different techniques for this. They have found that rotary retreatment files along with hand files or ultrasonic tips helps to achieve better removal of bioceramic sealers from the root canal. Ultrasonic activation generates high movement of fluid in a circular motion inside the canal space, which leads to better cleaning and dissolving of the sealers. Its cavitation effect also promotes the efficiency of these ultrasonic tips. We will now see how to remove separated instruments from root canal. When a separated instrument is present in a root canal, we have to attempt to remove it after taking various factors into consideration. Factors such as root dent in thickness, curvature of canal, type of material of the instrument influence this decision. For removal of separated instrument, ultrasonic tips can be used. For using these ultrasonic tips for instrument removal, a staging platform has to be created on the root canal wall just above the separated instrument. As you can see in the images here, a GG drill can be modified to create a staging platform. Then the ultrasonic tip is activated on this platform, and the vibration will help the instrument to loosen up and move toward the orifice. So this way we can retrieve a separated instrument using ultrasonic tips. Another technique for retrieving separated instrument is using instrument retrieval system. In this system there are microtubes and screw wedges. First, the microtube is inserted into the canal and the long part of its beveled end is oriented to the outer wall of the canal so as to engage the head of the broken instrument. After this, the screw wedge is placed through the open end of the microtube and it is passed down through the lumen of the microtube till it comes in contact with the broken obstruction. The broken instrument is secured by turning the insert wedge handle in a clockwise rotation. Another technique for retrieving separated instrument is wire loop and tube removal method. Needle and ligature wire is used in this technique. The needle is cut to remove the beveled end. Then both ends of the wire are passed through the needle from the injection end until they slide out of the hub end, creating a wire loop. You can see how this is made in this image here. This is then inserted into the canal. Once the loop has passed around the object to be retrieved, a small hemostat is used to pull the wire loop up and tighten it around the obstruction. Then the complete assembly is withdrawn from the canal. The next challenging aspect in retreatment is management of canal impediments. A ledge is formed on the canal wall during cleaning and shaping using hand and rotary instruments. So how to recognize a ledge? When a ledge is present, we will not be able to insert the files to the full working length. There will be loss of tactile sensation of the tip of the file binding in the lumen. We will get a feeling that the file is hitting against a solid wall. And taking a radiograph with the instrument in place will confirm the presence of a ledge. So how do we manage or bypass a ledge? For this, a small size file is preferred, preferably a 10 or 15K file. Pre-curve the file according to the curvature of the root as seen on the radiograph. Insert the file into the canal and rotate the file in a watch winding motion. Watch winding motion is rotating the file 30 degrees to the right and 30 degrees to the left with slight inward pressure. So while doing this, if resistance is felt, retract the file slightly, rotate and advance again. until it bypasses the ledge and reaches apically. Once you feel that you have bypassed the ledge, confirm it with a radiograph. Another thing is, while trying to bypass the ledge, it is very important to use a lot of lubrication with EDTA and also keep irrigating in between the filing. Root perforations might occur pathologically or iatrogenically during root canal therapy. If there is no evidence of post-treatment disease associated with the defect or the tooth, then no treatment is required. But if there is evidence of periradicular periodontitis associated with the perforation, repair can be done in one of the two ways, that is non-surgically or surgically. There are several factors which influence the repair of perforations. The first one is the level or location of perforation. So the coronal or furcation perforation can damage sulcular epithelium. So in general, more apical the perforation, more favorable the prognosis. Second factor is time. Regardless of the cause of perforation, it should be repaired as soon as possible so as to discourage further loss of attachment. Third factor is the extent of perforation. So larger the perforation, more challenging it becomes to create a hermetic seal. Fourth is the potential for successful management. How to do the repair of coronal third perforation? Firstly, hemostatics has to be used to control the bleeding. If the extent of the perforation is small, only sealing from inside the tooth is sufficient. Whereas if the extent of perforation is large, sealing from inside the tooth and then surgical repair is also required. Presently, MTA is the restorative material of choice for sealing perforations. So where aesthetics is a concern, a calcium sulfate barrier along with composite restoration or using white MTA, we can repair the perforation. However, where aesthetics is not a concern, super EBA or grey MTA can be used. Repair of middle third perforations. By nature of occurrence, these defects are ovoid in shape and typically represent relatively large surface area to seal. Access to mid-root perforation is most often difficult and repair is not predictable. Here the barrier material of choice is again MTA, and successful repair of mid-root perforation depends on adequacy of seal established by the repair material. Management of apical third perforation. If the perforation is because of over-instrumentation, re-establish the working length and enlarge with a larger instrument. Apical barrier of choice is calcium hydroxide, MTA or hydroxyapatite. If the perforation of the root has occurred in the apical third as such, negotiate the canal and treat the perforation site as a new apical opening and obturation is done till this point. Surgery is only necessary if a lesion is present apically. For the surgical approach, a combined intracoronal and surgical approach is done, which involves repairing the defect intracoronally, then reflecting the surgical flap so as to remove the overextended repair material from the periodontal space. Now that we have seen the steps that are involved in endodontic retreatment, we will see what are the potential complications that can occur. Greatest risk of heat-related tissue damage occurs during non-surgical retreatment. So what are the sources of the heat that is generated? First one is the use of heat to soften canal fillings to aid in their removal. Second is the use of ultrasonics to dislodge post or separated instruments from the canal, which can potentially generate enough heat to raise the temperature of the external root surface by 10 degrees Celsius or more. So what we should know is that temperature elevations of PDL more than 10 degrees Celsius can cause damage to the attachment apparatus. So these are the images from a case report. Image A shows a lower first premolar with lesion. B and C are clinical images and radiographic images after 1 month of retreatment. You can see tissue damage has occurred due to heat generated by ultrasonics, which was used during post-removal. These are few tips to reduce damage due to excessive heat. Firstly, use ultrasonic tips with water ports whenever possible. However, if the device does not have water port, use continuous coolant of air or water spray during usage. Take frequent breaks to let the tooth cool down. Avoid using ultrasonic tips on high power settings. Once the Gutta-Percha is removed and canal impediments are managed, next step is chemomechanical preparation of the canal. Irrigation is the most important aspect of canal preparation. So this is the irrigation protocol for endodontic retreatment. First irrigant which is to be used is 2 ml of 2.5% sodium hypochlorite for its antibacterial effect and its organic tissue dissolving property, so as to remove any necrotic pulpal tissue remnants if it is present in the canal. Activate it using ultrasonic for 30 seconds. After that, aspirate sodium hypochlorite and irrigate the canal using saline so as to remove any remnants of sodium hypochlorite. After this, 17% EDTA has to be used and activated for 30 seconds using ultrasonic. EDTA is used for its inorganic tissue dissolving property. Again, once this is done, aspirate it and irrigate the canal using saline. Again, repeat is the same process using sodium hypochlorite, and the final irrigant which has to be used is 2% chlorhexidine. E. faecalis is the most predominant bacteria in failed endodontically treated cases, and we know that it is highly resistant to all irrigants and intracanal medicaments. Chlorhexidine is found to be highly effective against E. faecalis, so this is the final irrigant that has to be used in a retreatment case. Which intracanal medicament can we use in retreatment cases? We know that E. faecalis is resistant to calcium hydroxide. This is because of its highly efficient proton pump, which helps it to resist high pH of 11.2. So a valid alternative to calcium hydroxide is to combine it with CPMC, which is a phenolic compound that has bactericidal activity because of its ability to break down cytoplasmic membrane, denature protein and inactivate enzymes. So in a study, Sequeira et al. Found that combination of calcium hydroxide with CPMC paste for 7 days gave a bacterial reduction of up to 90.9%. So this combination can be used effectively in retreatment cases. What is the prognosis of non-surgical endodontic retreatment? In the absence of prior apical periodontitis, it was found that in the incidence of healed cases after orthograde retreatment ranged from 92% to 98% for up to 10 years after retreatment. However, when a prior apical periodontitis was present, the incidence of healing drops to 74 to 86% after orthograde retreatment was performed. So the presence of a prior apical periodontitis affects the healing after endodontic retreatment. Our goal as dentists is to try and save the natural tooth to the best of our ability in the most conservative way possible. For this, adequate knowledge regarding the causes of endodontic treatment failure, technological advances for delivering the treatment, the procedures that help us to increase the quality of treatment is necessary. I thank all the doctors who are part of this presentation, and I thank Coltene for giving me this wonderful opportunity to present my topic here.